My dear friends and colleagues, today I am going to present a case that has been a benchmark in my career because this is the left eye of a lady who came to me completely blind. She had a presenting vision of PL positive, PR accurate in both the eyes. She had hypermature senile cataract in both the eyes. First, I operated her right eye, which was apparently normal. She got her 6 by 6 vision back, and then she showed her trust to me, and I went for her left eye as well. This is the patient's left eye, which has an old adherent leukoma. As you can see in the inferior region, she might have had a corneal ulcer with perforation, and the iris is sticking to the inner side of the cornea, on the undersurface of the cornea, like as you can see the pigmentation in the central part of the corneal opacity. So I took it as a challenge, and being surgeons, you need to be courageous enough to take some challenging cases as well. Life is not easy, and cases won't be easy. So as I have started, I have deliberately made the second side port in the inferior region and not just opposite to my first side port, because of the obvious reasons of the corneal opacity. So as soon as I have started my rexes, you can see the liquefied cortex pouring out, which makes things even more difficult. This is a hyper mature Morganian type of cataract with liquefied cortex all around and a dense nucleus on the inside. So the best way to tackle this liquefied cortex is to visco-express the liquid, decreasing the intralenticular pressure. And as I've raised the flap, I just felt that it would be better for me to get a good control of the rexes, not by using a cystitome but by a micro rexis forceps. So I have asked my OT assistant to just get me the microrexis forceps so that I can try to complete the rexis from the side port. I deliberately have not made the main port because it causes rapid egress of the visco, leading to frequent shallowing of the anterior chamber, and chances of rexis runout increase in that scenario. So I want you to pardon me for the field of view because the eye has just moved superiorly. As I have created a smaller rexis, a baby rexis, I am confident enough to enlarge it. By now, I don't think I'll be able to complete this case from this 3 millimeters of rexis. So I'll be cutting the rexis tangentially from a micro scissors, and I have deliberately not attempted to even sweep the iris to break those synecdoche, because I felt it is this area that I am able to see is enough for me to operate this patient successfully. A case like this, things can go really unpredictable. So you need to keep some things in the backup. You need to have a 3-piece IUL for this patient, because this patient is really poor and I was operating her for free under Ayushman Bharat scheme in India that runs under the current government. I had a 1-piece IUL planned for this patient, but if this kind of case is planned in your OT, I would recommend to keep a 3-piece IUL planned in just in case if you need to put the IUL in sulcus, and you should keep a CTR ready as well. Keeping in line with the nature of this cataract, I was also suspecting that the patient might be having zonular dehiscence, but till now, I think zonular health is fine. So as you can see, I have given 2 tangential cuts, one on the right and one on the left, and I've increased the rexis size to about 4 mm. Still, it is not an enough sized rexis for some newbies to attempt. For novice surgeons, I would recommend an even bigger rexis, but I was confident enough to attempt. phaco from this rhexis. The patient is kind of a cooperative patient because she knows that I will do my best. As far as I remember, I also gave her 3 or 4 of peribulbar block as well to increase her cooperation. And here we go. So I'm doing some gentle hydration in this patient because the cortex is already liquefied and I don't need a lot of fluid waves going through the posterior capsule. So gentle hydration is required, and as you can see, the nucleus is freely floating inside the bag. It is freely floating inside the bag, and at this moment I am just asking God for his blessings and putting some visco inside the AC. One more fear that I had while operating the case is the give way of. I had a fear of the corneal opacity giving way. Although it is a very rare thing that is encountered, but corneal opacities like these generally, you cannot predict the thinness of cornea as in this area, which can lead to blowout during surgery because of the AC pressure from irrigation. So things look strong. They're holding strong, and I am just trying to do some vertical chops, going as still and as stable as I can, burying my phaco tip down in the center of the nucleus. I have kept the fluidics as well as phaco energy low. It's a slow motion phaco, if I may add, and yes, I have got a good crack, which generally relieves me in cases like these. Half of my job is done when I establish a good crack. That is the toughest part. Phaco tutors and institutes these days generally start to teach a resident from the quadrant part, and what I feel is the most critical step in a phaco surgery is the chop. If you learn a good chop and a good rhexis, you are good to go. You won't fail in your career as a phaco surgeon. That's what I feel. That's what my personal opinion is. You should always strive to be a good surgeon who has a brilliant chop and the ease of controlling even those run out CCCs. So by now I have made some 2 tiny pieces and a bigger chunk, and as I am splitting this bigger chunk as well, I am confident enough and I bring this piece up and going to the quadrant removal mode. I've asked my OT assistant to increase some phaco power at this time because I don't think 20 or 30% of phaco energy will do the job. This nucleus is around NS 3 or 4. Not too hard and not too soft. Case is going good. I had explained this patient about her guarded visual prognosis because of the corneal opacity cases like these. You need to make the patient understand as well to not expect some magical results, and the patient should be given a reality check as well. We are mere mortals and not just tools in the hands of God. That's what I tell my patients. Don't expect 6x6, don't expect 6x9, 6x12. This patient, I'll disclose her final vision as the case completes. She regained most of her vision back. As her other eye was also PL positive when I operated her, she got 6 by 6 vision in her right eye, and she got a happy vision in her left eye, in this eye. Coming to the phaco part once again, 2 pieces have been eradicated and 2 more to go. I am further chopping these bigger pieces inside the AC. At this time, I'm also fearful about one more thing, because corneal integrity in these cases is also a little doubtful. You need to take care of Decimet's membrane as well in cases like these. Sometimes there is stripping of Decimet's membrane from the main port, and if you are unlucky, the Decimet's membrane can also come inside your phaco port, and boom, you can have a DMD as well. By this time, I'm really happy with what I have done, and whole of the nucleus has gone out. At this time, I'm asking the patient whether she can see the light or not, and what even increases my happiness even more is that she said, yes, I can see your light much better now. And one last piece of lens nucleus has remained, but because I am a little skeptical about posterior capsules flimsy nature, I have decided to put on the IUL first and then phaco the last remaining part of the nucleus. A famous surgeon from India, Dr. Amar Agarwal, had devised this IUL scaffold technique to complete the phaco. So I'll be putting the IUL first and then taking out this last piece. This makes the procedure much safer. I cannot afford to do a PCR in this case. Not in any other case as well. You should not be scared of posterior capsule rupture, but you should be efficient enough to know what will increase the chances of a PCR. A good surgeon is one who can adapt to the situations in split of a second. So I have put the IUL, and the leading haptic is inside the bag, and then now I'll dial the IUL up in the bag. If you ask me, there have been some cases that I am proud of in my life. This lady that I am operating is one such case that I am really, really proud of. As the case completed and she came to me after 7 days for follow up, she said, Doctor, I am going to my village back to Bihar, and I want to take a picture with you so that I can show my family how you look like. So at the end of the case, I'm going to show that picture to you. This is the best part of ophthalmology, because you change lives forever. She came to me with such a condition that she could not eat properly, she could not dress herself properly, she was unable to go anywhere. She was dependent on her children for everything she did. And now when she came to me after her second eye was operated, she got totally independent. I could see the happiness from her smile, from her family's smile. That is the most gratifying part of ophthalmic surgery. As the case has been completed, I have phacoed the last remaining part of the nucleus and hydrating the side ports and hydrating the main port. And I have done it. just like you all can also do it. Putting some intracameral Vigamox. And that's all from my side. I am going to end this case with a picture of me with my patient. Here you can see her happiness. Her right eye 6 by 6, her left eye is 6 by 18. Thank you so much. Have a great day ahead.